Welcome, everyone. Thank you for taking the time to join us today for our regional grand rounds. Today's webinar will explore the topic from barriers to breakthroughs, implementing the Eat, Sleep, Console model of care for families affected by substance use. Just going to share my screen here as well. My name is Alyssa Haight. I am a perinatal consultant with the Champlain Maternal Newborn Regional Program located in Kingston, Ontario. The Champlain Maternal Newborn Regional Program, also known as CMNRP, is a regional program whose goal is to improve perinatal and newborn care in Ontario Health East. Our regional program, which is comprised of many of you here today, works to ensure high quality, integrated services and care at the right time, at the right place, by the right provider, along the continuum from pregnancy through the postnatal period. I would like to begin by acknowledging the land on which CMNRP operates. We recognize that CMNRP's members and interest holders are located on traditional Indigenous territories across Ontario. The CMNRP office is located in Ottawa, which is built on the unceded Algonquin Anishinaabe territory. The people of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. I invite you to take a moment to reflect on the land from which you are joining us, as well as the traditional keepers of the land and the treaty relationship associated with it, or whether it is unceded territory. We recognize that Indigenous practices of health and well-being have been in place in this territory since time began and are maintained to this day. We acknowledge that there is much work to be done to honor Indigenous women's and families' pregnancy journeys and to bring reconciliation to healthcare in Ontario. We acknowledge our role in collaborating with Indigenous peoples to raise awareness of Indigenous peoples' challenges in the perinatal period and pledge to contribute to ensuring clinical perinatal care is respectful and safe. This is also a time to reflect on and acknowledge that harms and mistakes of the past, and to consider how we can each, in our own way, move forward in a spirit of reconciliation and collaboration. We are truly grateful to have the opportunity to live, learn, work, and play on this land. We remain committed and acknowledge responsibility, building and improving relationships for First Nations, Inuit, and Métis peoples. I would like to note a few housekeeping items before we get started. So today's presentation will be followed by a Q&A session. So please feel free to enter your questions into the Zoom Q&A box at any time during the presentation. We also encourage you to complete the evaluation following the webinar, as your feedback is valuable in helping us improve for future sessions. So it's now with my great pleasure to introduce today's speaker, Dr. Maddie Gallant. Dr. Maddie Gallant is an assistant professor at the Acadia Expansion Site at Cape Breton University and a perinatal nurse consultant with the Reproductive Care of Nova Scotia. Her research and clinical practice are embedded with implementation science and integrated knowledge translation. Maddie's research and clinical practice focus on healthcare innovations and knowledge translation with the goal of creating responsive and meaningful change for perinatal populations. So without further ado, I'm going to hand it over to Dr. Gallant to begin our webinar on Eat, Sleep, Console.
Perfect. Thank you so much, Alyssa.
Welcome.
I'm just going to share my screen. And it looks like it's sharing. Maybe
I can see your slides, yes.
Okay, perfect. I always like to double check just before we get started. So thank you so much for that wonderful introduction. And I'm so excited to be here and honored to have been invited to speak to you folks today about a little bit about my PhD work, my clinical work, as well as the area of research that I've been embedded in over the last 5 years. And so excited to share with you folks what we've learned here in Nova Scotia and how that may be applicable more broadly across Canada. So as Alyssa had mentioned, I'm Maddie Gallant, and I am an assistant professor as well as a perinatal nurse consultant. I've spent most of my clinical work caring with families who have been affected by substance use disorder, as well in that perinatal period. So it's an area that I am quite passionate about, and I'm sure you'll see that come through in my presentation today. Alyssa has already provided a land acknowledgement, and it was a beautiful land acknowledgement. But I also wanted to acknowledge the land that I am presenting on today. So I'm presenting from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. So I'm in the Annapolis Valley in Nova Scotia. I'm deeply committed to advancing equity for Indigenous peoples and communities, and it's my responsibility as a clinician, an educator, and a researcher to address the TRC's calls to action. And so today, in a way that my commitment is exemplified, is going to be through when we talk about the barriers and facilitators that we've learned through implementing the Eat, Sleep, Console model of care, and just constantly applying that equity lens in all that we do, and implementing, healthcare innovations into practice. I'd also like to share a contribution statement. Again, I present to you from a province that's deeply enriched by the contributions from African Nova Scotian communities who have been here in Nova Scotia for over 400 years. Their contributions have and continue to contribute meaningfully to our province's culture and heritage. These communities continue to face inequities in access to care within the health system and beyond, and I acknowledge my responsibility as a clinician, a researcher, as well as an educator to advance equity in all that I do. And so the objectives here on this screen, and I know that they've been shared beforehand, so I won't go through them all, but today we're going to speak a little bit about the 4 core components of the Eat, Sleep, Console model of care. What exactly makes the Eat, Sleep, Console the model that it is? Then we'll go into, after we kind of conceptualize what is the Eat, Sleep, Console model, we'll look into what facilitators may be present that could support implementation, as well as some potential barriers that may be present as challenges in the actual implementation, and not only the effective implementation, but also that effective sustainability of the model in practice over a long term. And so, although I'm sure this is a bit of a review, I wanted to make sure that we were all on the same page in terms of what is the Eat, Sleep, Console and what do we know about that. So the Eat, Sleep, Console model of care is a novel approach to caring for infants and families who are experiencing withdrawal. And so it was developed in response to the challenges that were identified due to the outdated model of care, which was the Finnegan scoring tool that had been historically used widely in caring for these families. And really, the Eat, Sleep, Console model of care moved away from that symptom focus and focused more on the functionality of the newborn. So it's focused on whether the infant was able to eat, whether they are able to be consoled, if they're able to sleep. And really what it did is it tried to move away from that pharmacological management and focus more so on centering the birth parent and the care for the newborn, as well as optimizing those non-pharmacological interventions. And so when we think about effectiveness literature, which is looking at is the Eat, Sleep, Console as an intervention effective, we see that it has been widely effective. We see positive patient as well as health system outcomes, and this includes things like decreasing the length of stay. It includes decreasing the need for pharmacological treatment and potentially increasing breast chest feeding rates, as well as, again, potentially patient or family satisfaction. And so the other key piece about this model is that it is largely nurse-driven. It relies heavily on nursing involvement as well as competency in delivering the main components of the model. And so it's important for us to just keep that in the back of our mind as we move forward and actually how do we implement this model into practice. And so as an intervention as a whole, we know that it's effective. We know that it can cause or create these, positive outcomes. But the question then becomes actually implement this model into practice effectively. And that's really where my program of research and where my trajectory began, was looking at, well, how has the Eat, Sleep, Console model of care been implemented across, Canada and widely? Like, what is that how? Like, how has it actually been implemented? And so we completed a scoping review. It was published in 2025, and that QR code, I've tested it, so hopefully it will work. It will take you to our scoping review if you wanted to have a deeper look. I'm going to be sharing some highlights from that as we go through the presentation. But what we found is that even though we were looking at implementation literature, largely implementation science focused literature, so actually looking at that, how do we take the intervention and put that into practice effectively? So looking at barriers and facilitators, strategies, that how to was largely underreported or wasn't named. And this made it a little bit challenging, or a lot of it challenging, and to try to figure out, well, how do we actually implement the Eat, Sleep, Console model into practice effectively? So relevant to this presentation, we mapped common barriers and facilitators that were identified throughout the study. Despite there being a lack of exploration or naming this exploration of barriers or facilitators, we could kind of gather a sense of what they might be through reading and analyzing the studies that we included. Additionally, what we saw is that there actually was no consensus on what the core components of the ESC model was, and that oftentimes it's been integrated in multifaceted approaches. So it was Eat, Sleep, Console model of care, that tool that was implemented, plus there was also rooming in, or plus an intervention for optimizing non-pharmacological management. So it was rarely just implemented as the tool itself. And so that led to me completing PhD research and looking at implementation fidelity, which is around how do we maintain integrity of implementation of an intervention like the Eat, Sleep, Console into practice when we have these contextual elements like barriers and facilitators that are present. And so I explored these gaps within my PhD, and I'm excited to share today, in combination with our scoping review findings and also my clinical knowledge, about how these findings could be applicable to your local sites. And so just a really brief overview of what I did in my PhD, just to provide a little bit of context in terms of where the knowledge that I'm sharing comes from. In my PhD, I interviewed direct care nurses as well as nurse leaders who had either used the Eat, Sleep, Console model of care or who had supported the implementation of it in Nova Scotia. And we used semi-structured interviews to explore implementation of the model, and that included exploring things like what were the challenges, the supports, and then largely looking at what are the model's core components. So what are those essential elements that makes the model the model? And so the rest of this presentation will be a combination again of that knowledge gathered from the scoping review, my PhD work, as well as the relevant clinical experience that I've gained throughout the last decade working in this space. And so when we begin with, and thinking about, okay, what is the Eat, Sleep, Console model? At first, or face value, you may be thinking that it's, well, if the infant is eating, if the infant is sleeping, and then if the infant is able to be consoled. But what we found through both my PhD work as well as the scoping review is that there remains a lot of ambiguity around the core components of the model. And so you can see on the screen here, these are findings that came from our scoping review and an image that came from a recent poster that we shared at the Canadian Association of Perinatal and Women's Health National Conference, where the model itself, so that ESC tool, which I think you can see my mouse, that is, a large portion of studies did include that, but they also included other core components like optimizing non-pharmacological interventions, education for staff and for families, PRN pharmacological treatment, collaborative and responsive approaches. And so you can see here that it's much more complex than just whether the infant is eating, sleeping, or being consoled. And so I don't have the magic definition of what is the perfect intervention of the Eat, Sleep, Console that will cause a decrease or will lead or hopefully will lead to a decrease in length of stay and decrease in pharmacological treatment and all those other effectiveness outcomes that we've seen. But through working with our scoping review, through my PhD work and clinical practice, what we found are these 4 essential components of the ESC model of care. And so we found that the birth parent as a center and partner of treatment was one component. Optimization of non-pharmacological care is a second component. The third is around maintaining the birth parent infant dyad. And then the fourth is that ESC assessment tool. And so let's dive in to each one of those to see what I mean by each of those core components. And so we found that supporting the birth parent was essential because of their role as a primary caregiver and the medicine for their newborns. And so, as I mentioned before, the Eat, Sleep, Console really moved away from leaning on that pharmacological treatment that we were using a lot with Finnegan scoring and actually leaning in more to that empowered engagement of having the birth parent use non-pharmacological management to help support their infant as they went through withdrawal. And really, what this did is it helped to put parents back into the driver's seat of their infant's care. So, again, that Finnegan's, that was more that medicalized model that took that focus away of engaging with the birth parent. The ESC model helped to really bring forward that collaborative relationship that was really grounded in empowerment and also in comfort, and that gave back birth parents the control that was historically removed with the Finnegan score. And so you may be asking, well, okay, what was that? What would that look like? And that may look like allowing parents to determine when the assessment should occur. So instead of the, 8, 11 to 5 kind of, and I'm sure that those numbers ring true for some individuals who have used the Finnegans before, instead of staying on that time frame, it's more about working with families and figuring out, okay, how can we engage in a flexible approach, also, ensuring that we're providing that assessment that these infants need, but also doing it in a way that's collaborative with families. Then the second core component is all around that non-pharmacological optimization. And so most participants that we interviewed emphasize the importance of that non-pharmacological management for those infants who are experiencing withdrawal. And again, that it departed away from that pharmacological focus and more to a holistic approach to care. And so most participants actually cited the importance of reinforcing the role of the birth parents in engaging in things like skin to skin, breast chest feeding, swaddling, quiet environments, using soothers. And all of these interventions could be parent led rather than relying on the nurse to administer the intervention, such as pharmacological management. And so, again, by leaning into that core component of non pharmacological optimization, it was able to then support that birth parent as partner and encouraging that empowering and partnered approach to care. The third core component was around preservation of the dyad. And so, in order to adhere to those other components around having the birth parent as a partner and then also optimizing that non pharmacological intervention, we really need to keep birth parents and infants together. And that just allowed, again, if the birth parent, the primary caregivers in that room were able to better support them in caring for their newborns. And this may require some creativity, whether it's, barriers, which we're going to talk about soon in terms of physical structure of the unit, in terms of resources that are available. Sometimes we need to get a little bit creative on how do we maintain that dyad and what could that look like within your site. And so I brought a quote. I didn't bring too many into this slideshow, but I really love this quote where it speaks to just that biological need of babies that they have to be with their birth parents. And so if we can support that biological need and have those families stay together, that can then in turn help support withdrawal for these little ones. And then finally, of course, the Eat, Sleep, Console model of the tool itself, I should say, is a strength-based approach to care. And so the ESC tool, as we see in that picture of the scoping review, it was reported as the most, readily included tool. But really, it's beyond just the tool itself. It's what it represents. And really what it represents is the fact that we are really focusing on what truly matters for these little ones, whether they're eating, whether they're sleeping, and whether they're being consoled. And so it was a less of a focus on symptoms, less of making the babies into these symptoms. And it required us to take more of a strength-based approach and more of a relational approach to care. And that really helped us to move away from the stigma that was innately ingrained in using the Finnegan's tool, and actually really encouraged us to look at babies for those normal, quote unquote, normal newborn changes, like, that night number 2 and the cluster feeding and waiting for the breast chest milk to arrive. That those are some normal periods of potentially fussiness or unsettled that all babies are going to experience. And so not labeling that necessarily as a withdrawal symptom, but rather as a developmental milestone or change that would be part of any normal newborn, or quote unquote, I should say, normal newborn. So considering those aspects. And that's really what the ESC tool has done, is really encouraged us to take this strength-based approach. And our scoping review also, although this isn't part of a core component, I just wanted to put a plug in here around strategies. And, strategies, implementation strategies could be a whole other full webinar discussion, and maybe that'll be the next one. But for today, I just wanted to mention just how foundational education is as part of implementation, as a strategy for implementation. As healthcare providers, we really need to have the education, the knowledge to support how we can actually care for families. And in order to provide this type of care, we need to understand why. We need to understand also the how. How do we provide, or use the ESC tool as a strength-based approach? How do we maintain the dyad? How do we engage in optimized non-pharmacological interventions? And so it's really important that not only do we understand those core components, but we understand going to implement those with integrity. What knowledge or theory do we need to have behind it to help us to support that implementation? And so what do these components align with? And so you might be asking yourself, why do these core components seem so familiar? Why, what do they align with what we do every day? And you're not wrong. You're definitely onto something. These core components that we've just listed, or that I've just listed, really align with the core principles of the family-centered maternity and newborn care that we have in Canada, and largely really universal care that we have for perinatal populations. We do try to empower birth parents in the care for their newborns. We do try to keep the birth parent and the newborn together. We do try to center, care and decision-making around the birth parent, and always, begin with non-pharmacological intervention. But the alignment really provides, or that the core components that I've just described and how those have been deemed, or at least described as core components of the model, really provides important insight into the ongoing stigma that exists in the care for families affected by substance use disorder. And so this stigma has really permeated into our current approaches in a way that universal perinatal care is actually not recognized as foundational approach to care for birth parents diagnosed with substance use disorder, but rather it's a core component of the model. And initially, this may seem like a detriment, but in all reality, it's actually, this lack of recognition is actually a a facilitator in a way to help us to combat that stigma head on. And so by actually naming these kind of perinatal universal approaches where, the birth parent is the partner in treatment, we're optimizing non-pharmacological intervention, and we're maintaining the dyad, it actually encourages us to be very intentional in incorporating of the core components within the care that we provide for newborns and their families affected by substance use disorder. And so again, it's not a detriment, but really it's a way that we can harness this motivation, this naming, this, talking about the elephant in the room, if you will, and actually empower and center care around birth parents to then support their newborns who are experiencing withdrawal. And so, again, I don't have a magic definition of exactly what the Eat, Sleep, Console and how it should be defined. But I think our scoping review, as well as my PhD work, has really provided us a solid foundation to begin the conversations, at least, of what does that implementation look like in your site. And so I really encourage you folks to consider before implementation, or even if you've already implemented, consider what are the core components of our implementation? What are the core components of the ESC model? Because that's not only going to help with the effective implementation, but it will also help with the sustainable implementation. And I'll speak to that a little bit more in the coming slides when we talk specifically about environmental barriers that can arise. And so now after we've understood what are the core components, next we need to go in a little bit deeper and consider what are the facilitators and the barriers to actually implementing these core components or the model itself into care. And so beginning with this first facilitator is all around the fact that the Eat, Sleep, Console model of care itself is a facilitator. So as an innovation, the Eat, Sleep, Console model of care is seen as a strength-based, a positive change from the outdated model of care. It's a holistic approach. It looks beyond labeling the newborn as symptoms, and it helps us to, again, move beyond that innate judgment that's present within the outdated scoring tool. And for the most part, most nurses, want this change. They want to move away from that medicalized model and move towards more of that empowering, centering care, and it to be more aligned with the universal perinatal care that we're used to offering all patients and all families. And so it's really important to harness that, the fact that the innovation itself, the Eat, Sleep, Console model of care, is a positive healthcare innovation, and we can leverage that in a way to help support implementation. The second piece is around it's important to consider the group and who is implementing it and also who is going to use the Eat, Sleep, Console model of care. And so the person that's implementing the model and using the model really matters. And what I mean by that is that we have to think about the contextual elements of the person. So each person has their own context. So if we think about, for my PhD study, I learned that when you have experience caring for families affected by substance use disorder, who have maybe you've used the Finnegans in the past, you already have this foundational knowledge, and whether or not it's a foundational knowledge of working with families, or maybe it's knowledge that the Finnegan score isn't enough, that gives you kind of that, if you will, a leg up, or at least a foundation that you can build upon and moving towards a different model. The other side of it, though, is if you have less experience, you're not biased by perhaps the care that you've provided in the past, or maybe that comfort of care that you've provided in the past, then you don't have any preconceived notions of caring for families affected by substance use and using the Finnegan's score, essentially. And so then it's all you know. The Eat, Sleep, Console is all that you will know. And so that, in a way, is a facilitator. And again, just that comfort and passion and caring for families. If you have individuals who are champions or who have led this work in terms of, that knowledge, that support, that guidance, that really have embedded themselves in improving care for families, it's really important to leverage those individuals to help support not only effective implementation, but also sustainable implementation over time, where it's not just a one-time blitz of education, but rather they're constantly available for those unique cases or for, further discussion if individuals have additional questions. And so this particular facilitator is just about, really thinking about who it is that's going to be implementing and using the model, and what about their contextual experience, comfort, motivation could be leveraged in support of implementation. Then the other piece is around the gift of time. And you may be kind of laughing a bit at me when I say the gift of time, because we all know that we have a lack of time in our day-to-day life, let alone in the healthcare system where things move very rapidly. But I think it's just more about having that quality time as well as the robustness of the time that we have. And so it's important to, prior to implementation, socialize the idea that change is coming. Give time for individuals to actually use the model. So maybe they practice in case-based scenarios or simulations, that they're able to really interact with it so that those questions that maybe are coming in the back of their mind of, is this going to be enough to care for babies if we're not focused on the symptoms, that they can voice those out loud so that it's not all of a sudden, this is what we're doing tomorrow. And then it's this panic of, well, I don't know how to do it. And how do we care for families? And, making sure that we're doing the best that we can for families. So again, having that gift of time, considering a robust pre-implementation period, which again, it doesn't need to be a long time, but rather just that time, dedicated time supported to talking about it, whether it's at staff meetings, through newsletters, on the floor, word of mouth, but at least talking about them and socializing that change is coming. And the other piece is around having a systematic or a theory-informed approach. And we speak about this in our scoping review a lot, but just having some sort of systematic way or a theory that can help guide, and I'm going to speak to one at the end of this webinar, can really help to ensure that we don't lose some of those missing pieces in terms of like evaluation, but also in sustainability. Because sometimes we do a really great job of implementing something from the very beginning because we put so much effort into actually, giving the gift of time, socializing the idea. But then once it's in practice, we kind of let it go to the world. And we do need to have those checkpoints as well as those periods of intentional, sustainable strategies to help ensure that the knowledge that we've imparted at one point is consistent over time. And so, it's really important, or what we've seen as facilitators is having that robust pre-implementation period and using that systematic approach to ensure that sustainability. And then two more facilitators for you to consider. And as I mentioned before, was around that education as a foundation for success. And the education, as I spoke to before, around healthcare providers is definitely very important. We need to have an understanding of what we're doing and why. That's part of our evidence-based practice. But we also need to support birth parents in their education because we're putting a lot of pressure, a lot of responsibility on parents to be the center of treatment during a time that can be potentially re-traumatizing, vulnerable. A lot, is happening during that early postpartum period. We want to ensure that they're aware of, what is the potential role that they can have with their newborn. What does that look like? What supports may they need so that we can navigate that space and ensure that that education is provided prior to actually having their newborn. And it's important to have dynamic education, whether it's asynchronous, synchronous, but then also hands-on. Some of our participants shared that learning the content was important, so that theory around the behind the why, but it was even more critical to understand that hands-on learning approach. And so, what exactly is happening at the bedside? What does neonatal withdrawal look like? And how do you use the tool itself in care? And so keeping that in mind, and although, train the trainer or buddy shifts can be expensive to have two nurses at the same time, there's different ways that we can incorporate hands-on learning, whether it be through case-based scenarios or simulation. So you can get creative depending on what resources are available. The other two pieces here are just around paid education. So having, valuing that time and providing that paid education or compensation of some sort for completing the education, and also learn from each other. And so we don't need to reinvent the wheel constantly. Oftentimes we practice in silos depending on our institution, but it's always great to learn from each other, not reinvent the wheel, and actually leverage some of the key things that are working in other sites and try to bring those to your site and adapt those. And then finally, the last facilitator is again just around understanding what are those resources that are needed to sustain the core components. And so this could look like childcare coverage, cuddlers, and as I alluded to before, just how are we going to best support these families to be the center of treatment, to be the medicine for their newborns. And it also may cause or may lead to some infrastructural changes and practice changes, which that could look again like financial support if there's a partner that's going to be in hospital with the birth parent. How can we support nutrition? How can we support like medication administration if needed? And then also compensation if there are additional challenges that are present for families. And so really broadly asking, how can we support these families, and listening to families to understand what is the best way that we can support them, and having those conversations in the prenatal period rather than in that kind of postnatal period where everything seems to come to a head. So we've just started with that strength-based, facilitators, what can help implementation. Now, of course, there's always going to be barriers on that flip side. And so, again, these are just areas to consider in terms of what could be relevant in your local setting. What we found was around environmental hurdles. And one of the things is around the nursing schedule. And so we talked about this briefly before the webinar started, just, what is the best time to host a webinar? What's the best time to have, asynchronous or synchronous education? Is it better virtual? Is it better in person? And so there's a lot of discussion on, especially with nursing, if we have different shifts, different, set groups, it can make it challenging to find a one-size-fits-all education and rollout. And so being very creative and needing to be creative in order to address that. The other thing that we found was around this phenomenon of lulls in admissions to the unit. And this is around the fact that not always will we have families affected by substance use within our care. Perhaps they'll come within lulls or differing presentations. And what that leads to is challenges in maintaining the competence, the experience, and also the exposure in caring for families. So you may, do your education, but then maybe you go a couple weeks without actually caring for families, or maybe you're not assigned to families who are experiencing substance use and their infant experiencing withdrawal. And so it's important to consider that, because if it's been large periods of time since you've had that hands-on learning or had that theoretical learning, that can be a barrier in actually successful implementation. The other piece is around external impacts like COVID-19. And I alluded to this a little bit before, just around how sometimes in terms of sustainability, if we're not thinking about those core components, when we have impacts like COVID-19 that limits the amount of visitors that can be present, we don't realize how much that's actually going to impact our ability to actually deliver the care that we are meant to. So for instance, with COVID-19, a lot of our sites, across Canada, across the world, had limited so that there was no visitors or there was a limit of one visitor. So if you had newborns who were experiencing withdrawal, you had a birth parent who maybe had other children at home that needed to go back and forth. Well, there was a period of time where you actually couldn't come back after you've left. And so that has added an additional barrier of, supporting that birth parent and the needs that they may have. The other thing is about having somebody that can sub in and out. If you have a partner that needs to go to work or needs to access if they need to medication outside of the hospital, again, that those policies and procedures that were put in place limited the ability to actually do that. And so it's important that we consider, what are those core components and how is that going to impact our implementation and the sustainable implementation over time. And so again, COVID-19, although maybe not quite as prevalent in terms of policy and impact as it was in 2020, it still begs us to consider what impacts could come if we did have another situation such as that. And then, as we mentioned before, on the context of the human being or the context of the person that was implementing, we also need to consider the context of the person as well as potential barriers. And really, it comes down to the fact that there's inevitable complexities in both nurses as well as birth parents. So with birth parents, we have things like, competing priorities, geographical differences if they live further away, they have potentially children at home they need to travel back and forth to see. Also, birth parents continue, as I mentioned before, to be impacted by stigma. And so, we heard that there's perceptions that parents who had, previous negative experiences maybe had anxiety around the diagnosis of withdrawal. And so, because of the stigma that was within the health system, that further complicated the implementation process, and that perhaps birth parents might have been a little bit more wary. And again, these are perceptions of birth parents from nurses, so not firsthand voices, but just the perception, something that we do need to consider, and also an area for future research to better understand how that stigma impacts the implementation process. But it is something that we do need to consider. The other piece around nurses, so again, it could be a lack of education, a lack of buy-in. People get comfortable engaging in what they've become used to day to day. There could be a fear that if we're not focusing on those symptoms, are we going to miss, an extensive withdrawal? And then also that knowledge and comfort. If you don't have knowledge and comfort in caring for families, it can be a bit, we heard a bit intimidating because of the social complexities that do exist in caring for families who are affected by substance use disorder. And this could include things like involvement with child protection services, dysfunctional relationships, polysubstance use, and these are just some examples that really could affect any family. But in particular, if nurses don't have that knowledge in navigating those social complexities, it can make it a barrier in terms of implementation. And then the last piece that I wanted to mention was around language. And language, we saw this in our scoping review, how the ESC model of care is based in the English language. And our scoping review showed that there were studies that actually highlighted a delay in outcomes seen in equity deserving populations due to a predominantly English implementation of the ESC model of care. And so for families that their first language was not English, or who also experience systemic oppression. And so it's really important in considering the language piece around constantly applying that equity lens and that barrier that may be present if we're using an English-based assessment tool for families who their first language is not English. And then the final barrier that I wanted to speak to is around institutional roadblocks. And so, some parents shared, or sorry, not parents, some participants shared that they observed that families were often protective of their newborn, and again, impacted by those previous negative experiences and those anticipatory fears of having their children taken into care, or perhaps that prolonged hospital stay that we used to see a lot with the Finnegan scoring. And this may have led to some hesitation from birth parents in being a partner in their care. The other piece is around short staffing, and I know that that's not a isolated experience, but it's not just about being short staffed, but also not having the staff that have had the experience or training. And so it can get into some challenges when you're implementing and you don't have the adequate knowledge within the staff to support new staff who are caring for families. The physical structure of the unit. So if the unit isn't able to maintain or preserve the birth parent infant dyad, we've already seen how at the beginning, how I talked about how that's a core component and how that could impact the ability to partner, with the birth parent, but also to, maintain those and improve those non-pharmacological interventions. And then also around that absent education opportunities. And this isn't necessarily the initial implementation piece. I think we do a really great job, or I like to believe we do a really great job initially implementing something. But it's about that ongoing and sustainable education. Oftentimes we need that reminder, that refresher on, okay, we haven't had to care for families, or I haven't had to care for families in a period of time. Where can I go to access some information that can help support that sustainable implementation of the model over time? And again, that doesn't just go for the nurse, but also for the birth parent. And so I've just provided a quick snapshot of what some facilitators and some barriers could look like, but I really encourage you to take a peek at the review that I showed at the beginning, the QR code, and see which others may be supportive in your local setting or maybe potential barriers in your local setting. And this is just a reminder that it's not a one size fits all. We're all, we can learn from others, we can learn from the scoping review, we can learn from my primary research, and it really gives us a starting point of what questions we can maybe ask in our local site. But really it comes down to asking those questions in your local site and actually participating and understanding contextually what impacts each site individually. And so I know I'm coming to a couple minutes left, but I just wanted to throw this up here. This is the knowledge to action cycle. And I threw this up here, was created by Dr. Graham and colleagues in 2006, I believe. And this QR code brings you to the Center for Implementation. And that's just a screenshot of their write up on the KTA, or the knowledge to action cycle. And it's a really great, I think, intuitive cycle for healthcare providers to use, and actually moving innovations into practice effectively in a systematic way that encourages us to adapt our knowledge to local contexts, to assess barriers and facilitators, like I mentioned, to then tailor and implement the interventions using specific implementation strategies, which I alluded to is a whole other topic, and then monitoring, evaluating, and then also sustaining that knowledge over time. And so it's not just a kind of one-stop shop. You do need to continue to support that sustainability over time, however that looks for your particular site. And so a sincere thank you to everyone who has come today, and also to the funders for their generous support throughout my PhD work, as well as all my co-authors in the scoping review, in our Cap1 presentation, as well as in my PhD work. So that is about it for my presentation today. I'm very happy to answer some questions. I may go, Christina, do you want me to go to the next slide now?
Yes, thank you so much. That was absolutely fantastic, Dr. Gallant, and congratulations on your recent PhD defense. So that was just a couple months ago, not even, that you received that designation. So really, really important work, and we'll go to the question and answer in a second. But we just wanted to share some research that's happening. So I'm Christina Canton, a nursing research scientist at the CHEO Research Institute, and I'm working with Dr. Kelly Zwicker, who's a community pediatrician, to really look at how things are going with the implementation of the Eat, Sleep, Console model in Ontario hospitals. And so this is a Research Ethics Board approved survey that we invite you to complete if you're interested. It's about 15 minutes or so, and we're really trying to get a sense of where our organizations are at with implementing. We did rely on Dr. Gallant's scoping review in terms of those well-defined barriers and facilitators. So we think that this is a really important opportunity to see what we could do together. So the data from this study will be used to guide next steps in terms of really supporting organizations towards this family-centered model of caring for substance-exposed babies. So there's the QR code to scan to the survey, and then CMNRP popped in the chat the link as well. And in the chat, there's the article link to the scoping review, and then also the link to the knowledge to action framework. So that is a phenomenal implementation framework. So I don't see any questions yet. So in the bottom of the screen, there's a Q&A button that you could write your question in, and Alyssa and I are going to be looking at that box for your comments, but I can get things started. Do we have another screen, or should we stop sharing
Nope,
the
we don't have any
slides?
more. I'm happy
No more
to.
slides? Okay. Yeah, maybe we could share the screen. And oh, there's Dr. Zwicker as well on camera. So that's wonderful. So I guess I just had a question, about prenatal education, for families. So there's such a focus on, getting ready for, buying the things for having a baby, but really understanding how we care for babies after birth, particularly this population with the substance exposure. So Maddie, do you have any comments about things that have come up in your own experience or in the literature regarding prenatal preparation?
Yeah, it's a really great question. And honestly, it's a huge gap in terms of like the patient experience. That's kind of my next step, is to really hear from birth parents and hear that first voice experience and what exactly do they need in terms of education support. Ideally, we would love to co-design some sort of education toolkit that would support families, not just in that prenatal period, but right through to that postpartum kind of first year of life to support families. There are some, and when we did the scoping review, there really was only, I'm trying to think exactly, don't quote me, but I'm pretty sure that we only had one study that really looked at the parental experience of the sleep console and the implementation, and really it limited in terms of that discussion around like what supports do you need. And I think the pendulum really swung from one far on one end of being very medicalized and very nurse centered and driven and focused on that pharmacological management, and then we swung completely the other way, which is where we needed to go in terms of the non-pharmacological care supporting birth parents. But there hasn't been a lot of questioning around, okay, but what do birth parents need to be able to do that? So in an already, heightened situation where newborns are experiencing that withdrawal, where they're experiencing, families are experiencing challenges in terms of access, in terms of being away, far away from their homes, how do we support those families to stay in hospital for 5 to 7 days as a minimum, or potentially longer, depending on what the withdrawal, looks like? Because we know even with the Eat, Sleep, Console model, we still will have newborns that do need pharmacological management. Just ideally, it's not months and months on end like we were seeing with Finnegan's score. So it's not a super satisfying answer in terms of what's available. There's not a ton that's available, but it is part of kind of that next direction, and an area that very interested in further developing, but definitely has to be led by that first voice experience and what families need. So
Yeah, I love it. And I know there's some grad students on the call. I recognize some names. So there's an opportunity, a wonderful research study for you, qualitative interview of the experience of families, who have this exposure and their experience through different models of care. That's so, so important. I love how you were really focusing on, the similarity between the concepts of family-centered care and how it is absolutely congruent with the Eat, Sleep, Console framework. And you present this challenge just saying that, yeah, sure, there's gaps in implementation, but we can actually use that to say this is the standard of care. Like, this is how we provide care to mother-baby dyads in our province. So why are we caring for this population who's exposed to substances in a different way? That becomes an equity issue. So I think the argument that you present is really quite brilliant. It's very simple in its brilliance. And CMNRP has done a lot of work over the years about family-centered care, and there's a toolkit and a lot of leadership from our family advisory committee members. So this is just absolutely perfect. Alyssa, I'm not seeing any other questions in the chat or the Q&A. Did you have a question or a comment,
Yeah, I
or do
do
you
have
want
a
me to keep
question.
going?
I have a
Okay.
question as well. Yeah. Thank you so much, Maddie. That was a very insightful talk. I really appreciate it. I think you did such a great job of just demonstrating how valuable this is for really the entire family unit. And I really liked how you've outlined how it's such an innovative approach that we need to use as, this entire model of care and not just one piece of it. So my question is kind of thinking about those who might have one of those barriers related to the physical constraint or structure of their unit, and perhaps caring for these infants who are unwell. So maybe they're not able to be maintained in that dyad. Do you have any advice for those that they might be able to kind of be at the bedside more often or offer a bit more of a modified approach? So thinking about an infant who perhaps would be in an ICU setting or not have that dyad maintained.
Yeah, it's a really great question. I think really goes back to that, making sure that we understand like what are those core components, because if we think about especially the unwell and newborn that can't eat, for instance, how do we assess newborns who are experiencing withdrawal when a third of that assessment is eating? And so again, an area that needs some more research in terms of like how actually do we appropriately use this model to care. But I think it really comes down to that being creative and partnering with families. And I think having that early education for families and for them to understand what is the potential, I guess, for their role. Because of course we can't, force any families to be the center of treatment. That's not what we're doing, but rather we're empowering them and really, leveraging, but also like uplifting what their role will do and what their role can do for their babies. Oftentimes, I've heard just about that guilt, and I'm sure we've all heard about the guilt that we've, heard from families who have are watching their newborn experience withdrawal. And being the center of treatment can help to give them that tangible action that they're doing something that's actually improving the care for their newborn and is supporting their newborn, and that they're the ones that the newborn is looking for. They're looking for their birth parent. They're looking for that primary caregiver that can be present and provide that skin on skin or breast chest feeding, swaddling, the quiet environment, and just being in that room together. And so I think, again, not with any concrete evidence, but rather just accumulation in terms of my, clinical expertise in this area, is just about being creative. And when we have those physical challenges, how do we partner with not only our patients, but our healthcare providers, our staff, to figure out what does that look like? Because of course we can't always provide that extra time to families if we have a couple of other pairs that we're, caring for, a couple other babies that we're caring for. And so how do you, equitably share yourself in terms of that care provider? So I think it's very unique, very individualized, but ultimately comes down to that openness, the transparency, and just naming that impact that birth parents can have on their babies. And if they do need to step out for an hour, maybe we coincide with a time that we're able to as nurses to support. And maybe that's when we do our assessment, or parts of an assessment, or maybe something that maybe birth parents could step out for. Or maybe we do it, if they're sleeping or need a shower. Again, just trying to leverage those resources or those times. But it speaks to the financial need, right? If we need to help support and provide that respite care or provide that ongoing support for these little ones so that they're not left alone, and swaddled or in an incubator, how do we leverage the supports that we have available? So on one of the slides I talked about cuddlers and volunteer organizations that come in to cuddle and provide that holding or that physical touch for little ones. And how can we leverage that in situations where we have families that do have geographical differences and do need to leave maybe the bedside for periods of time when their newborn's unwell? So again, not a perfect answer, but rather I think it's a conversation and just how can we be creative and try to get out of that box that historically we've been been stuck in, and be creative with what resources that we have, but also transparent in the resources that we don't have as well. Not everything is perfect.
Yeah, thank you so much. I think it's a very honest answer that you say. There's a question here about the context in Nova Scotia. So lovely talk. How many birthing centers are there in Nova Scotia, and over what time frame were you seeing the implementation of this approach in these centers? So in your clinical and your consultant role, what are you seeing across Nova Scotia?
Yeah, so we have about 9 centers total across Nova Scotia with various capacities. And then the implementation began in 2019, I believe. And it's really just kind of permeated over the last, I guess, where we're 26 now, so the last 5 years. And again, depending on, historically families were cared for at central facilities rather than rural sites. And so that a lot of the work that I've supported with the reproductive care program, we developed a clinical toolkit to support healthcare providers in caring for families affected by substance use and newborns experiencing withdrawal. And the kind of motivation for that project was actually to bring families closer to home so that those other hospitals that may not be caring for families or who are traveling long distances would be building the capacity. We're just in the process of doing something very similar as you folks, but exploring, what facilities are caring for families and what has that implementation looked at. So I don't have a great in terms of exact answer. But I'd say probably over about 5 years, that's where we've seen the shift in moving from Finnegan's to that Eat, Sleep, Console model of care.
Perfect. Thank you so much. And yes, we can continue to collaborate. And we know our friends and colleagues in British Columbia have been huge supporters, very embedded in this work as well. And so I love how nationally we share resources, we collaborate together just to really spread and scale these innovations. I love this. I love what you're saying about nurses providing really strong leadership with this model. It's a strengths-based model. It's really positive and again, embedded in family-centered care. So I think what we're hearing is a call to have conversations at your local organization. Like, what does this look like? What's the opportunity? And I'll turn it over to Alyssa if there's any final closing words.
Yeah, thank you so much. So I just want to say, extended a sincere thank you.
Oh, you're muted, Alyssa.
Thank you. I thought it didn't click fully. Thank you. I just want to extend a sincere thank you to you, Dr. Gallant, for such an insightful and engaging presentation. I think the knowledge and perspectives that you shared today will undoubtedly help support and improve care for these infants and their families, not just across our region, but everywhere. And I'd also like to thank both Christina and Dr. Zwicker for sharing the regional survey to help support these implementation efforts. I think that your work and collaboration is greatly appreciated, and I'm really excited to see what's to come for our area with this Eat, Sleep, Console model of care. So we're going to be adding the evaluation in the link for the evaluation in the chat for everyone here to access. So please know that your feedback is very important to us, and it will help guide us for future regional Grand Round sessions. Following today's webinar, the video recording will be sent out to all of our registrants, as well as a link of the recording will be found on the CMNRP YouTube channel, and access to this will be posted on the CMNRP website. So thank you so much to everyone for joining us today. I hope you have a wonderful afternoon. And we look forward to sending out more communication about our upcoming next regional Grand Rounds soon. Thank you so much.
Thanks, everyone.